So again, we have the medial meniscus is more of a C-shaped, and then the lateral meniscus is more of an O-shape. And again, it's going to be thicker to the posterior part. And then on the medial side, it's going to be attached to the medial collateral ligament. Okay, so that's going to be significant because we'll talk more about, you have the triad of the knee, which is the things that get injured commonly together, which is the ACL, which is the anterior cruciate, the medial meniscus, and the medial collateral. So a lot of times those three will get injured together. And then what's going to become significant when we're doing some of the tests before, we'll be doing a test to test the meniscus of the knee. And when you laterally rotate, it puts the medial meniscus more under stress. And then when you internally rotate, it's going to put the lateral meniscus under more stress. So we'll be doing some tests before where we're going to internally rotate and test the medial meniscus, and then we're going to internally rotate to test the lateral meniscus. If anybody's coming in and you didn't get one of these handouts, this is some parts that were missing in the notes. You'll need to add that in to the appropriate spot. Question?
Internal rotation is testing for lateral?
Yeah.
Okay.
When we're talking about the knee, there's a few things that are going to be stressed differently when we turn the knee. So what you want to do is think of in terms of which part is being brought to the front. So when you turn this way, you're bringing the medial meniscus to the front and also the anterior part of the joint. Versus if we're going to turn the other way, then we're bringing the lateral meniscus to the front and also the anterior part of the joint ligaments. And then in this case, this posterior part here is being brought back. And we'll talk more about that later because there's certain tests when you add different torques to the knee that you affect the structures a little bit differently. So again, now the lateral meniscus is the O-shaped. And then it's going to be strained more when we internally rotate. And then as far as the range of motion that occurs at the knee, it's primarily a hinge joint, or more specifically a modified hinge joint. So the primary motion is going to be which pairs? Flexion, extension. And extension basically is going to be 0. Some people will have some hyperextension, but normal extension is 0, and then flexion is like this. Now, when you flex the knee, you are going to have some internal external rotation. Because if you try here, I mean, you try to internally and externally rotate, you're just going to move with the ankle. But if you bend your knee and you go like this, you will feel that the tibial plateaus can move in and out. All right. The internal external rotation is not really anything that's going to be measured. So when we're talking about with goniometers and inclinometers, you really only measure a knee flexion extension. So then the loose pack position is going to be about 25 degrees of flexion. Close pack is going to be extension. Full extension with, more specifically, a little bit of lateral rotation. Okay, so when you're at close pack position, that's when all the ligaments are tightened up and the joint is at maximal contact with the surfaces. And a lot of times that's when you're going to have a knee injury. You know, if somebody's in this close pack position like this, and you go and you smack them from the side here, the ligaments are taut, they're going to be more likely to pop, whereas if you have a little bit of flex in it, you've got some give or some responsiveness to the knee. Doesn't mean that you still won't get hurt, just that it's not under as much tension when it's a loose pack. And then the capsular pattern, it's going to be equal limitation of flexion and extension. Okay, so now we're going to talk about the ligaments. We have two different pairs of ligaments. You have the cruciates, and then with that you have an anterior and a posterior, and then you have the collaterals. You have a medial and a lateral. Now the cruciates are inside of the joint capsule, and the collaterals are outside of the joint capsule. So if you injure the cruciate ligaments, your whole knee can swell up like a big balloon. Whereas if you injure one of the collaterals, it's more likely just to swell locally at that area. And then the way that you can remember these names of the cruciates is they have to do with where they're attached onto the tibia, and they have to do with what motion is limited on the tibia. So you have the posterior cruciate, which attaches to the posterior part of the tibia and moves anteriorly, and it limits posterior motion of the tibia in relation to the femur. So if you just think of them in terms of the cruciates, their name has to do with more how they relate to the tibia rather than the femur. So like I say, the posterior cruciate is going to attach more to the posterior part of the tibial plateau, or the intercondylar eminences. And it has to do with limiting posterior translation of the tibia in relation to the femur. The posterior cruciate limits posterior motion. It attaches to the posterior part of the tibia, and therefore it's going to attach more to the anterior part of the femur. Right? Then conversely, we have the anterior cruciate, which is going to attach more to the front part of the tibia, and therefore it's going to attach to the posterior part of the femur, and it's going to limit anterior translation of the tibia in relation to the femur. And then those cruciate ligaments, they cross inside of the knee. You know, the word cruciate meaning cross, so that they will cross inside of the knee. All right, so then the anterior cruciate is going to limit what kind of motion? Yeah, anterior translation of the tibia in relation to the femur. All right, so then conversely, the posterior cruciate is going to limit what kind of motion of the tibia? Posterior translation of the tibia in relation to the femur. And then the medial collateral is going to be on the medial side. Lateral collateral is on the lateral side. And then the medial collateral is going to limit, what motion is this called? Where the distal part of the extremity moves away from the midline is called what? Valgus. And then the lateral collateral is going to limit varus motion. All right. So then the way that the medial collateral is going to get injured is somebody's going to get hit from the side like this, forcing the knee out that way. And then lateral collateral is going to be hit on the medial side, forcing it, opening the other side. And then what's more significant is that this medial collateral ligament is closer into the knee, and that's going to attach to the medial meniscus, whereas you can see here, this lateral collateral is out on the fibula, so there's space in between there, so there's no direct attachment from the lateral collateral to the lateral meniscus. And then this lateral collateral, it also gets into the same attachments where some of the quadriceps, the hamstrings attach. So you have the biceps tendon and also the iliotibial band and the iliotibial tract. So there's other structures that attach on the same area as the lateral collateral ligament. And then you can examine both of these collateral ligaments at different amounts of flexion and extension. So you can examine it with full extension, and then you also want to check the knee in different amounts of flexion. Okay, when you get into this point here, the ligaments are going to be pretty slack, so you're not going to evaluate too much. So you want to have kind of a middle point of about 30 degrees of flexion, and then also at neutral. So when we examine the collateral ligaments, it's basically going to be the same thing as what we did in the elbow, except the knee bends the opposite direction of the elbow.